Hello, everyone. Thank you for tuning into our podcast. Today, I have Dr. McCracken, Physician Advisor at Northeast Georgia Health System, Dr. Swati Gaur, Senior Medical Director for Long-Term Care Facilities at NGHS, and Dr. Cory, Duncan, Medical Director for Emergency Department, Gainesville, joining me. Today, we're going to talk about a really hot topic, urine culture diagnostic stewardship. I think that's something we have really focused on and one of our areas of interest and opportunity. So I'm really looking forward to hearing more about what you do in your roles and what does this really mean to your urine culture diagnostic stewardship in your settings. We'll start with you, Dr. McCracken.
Sure. Well, I work as a hospitalist and a physician advisor. I work in the care traffic control, which we're involved in trying to move patients appropriately through our system. And also, we're involved with Dr. Bauer, co-chair of the medical MRUR committee. We got involved in the, asymptomatic bacteria, the overuse of antibiotics. And as we started looking at this, we really were surprised at the impact that this had on our system. And in terms of what it, how I define it, what it means, it just is making sure that we're treating a urinary tract infection when it's a clinically plausible diagnosis, that we're not just treating it based on the pyuria in the UA, or that we have a culture that may be a colonization.
I think it's almost become a default diagnosis when we don't know what's going on, if a patient is coming with altered mental status or if the presentation is not clear. And Dr. Gaur, again, you practice in the long-term care setting. Again, can you please explain more about your role? What do you do in that setting? And what does urine culture diagnostic stewardship mean to you?
Yeah, what a great question, because as we all know, it is such a prevalent topic in post-acute care area. So in post-acute care, I am the medical director for post-acute care facilities, 2 of them, and then the senior medical director over all 3 of them. I also have been the chair of Infection Advisory Committee with the Society for Post-Acute Long-Term Care Medicine, actually during COVID time, and work with Georgia Antimicrobial Stewardship Committee. So, we get so many instances of people or nurses coming up and saying, oh, the urine looks funny, can we send a urine? And so really, diagnostic stewardship is so important in post-acute care area. You talked about asymptomatic bacteriuria. We know that in post-acute care settings, 50% of women and 40% of men, who are residents in post-acute care, are going to have asymptomatic bacteriuria. So it is incredibly important to be able to tease that out and not unnecessarily treat them with antibiotics, because as we know, then it leads to C. diff infections and creation of MDROs and transmission of MDROs in long-term care setting. So it's a cascade that happens. So it's incredibly important to stop poor practice at the beginning.
Absolutely. I think that is so important. And just again, as you mentioned, when we actually start treating this positive urine cultures as UTI, there are a lot of downstream effects like C. diff, development of drug resistance, of course, increased healthcare costs. And actually, Dr. McCracken, you shared with me recently about this study or this observation that treatment of asymptomatic bacteriuria can lead to superinfection and increased risk of UTIs in the future. Dr. Duncan, we have had so many discussions about this. You practice in the emergency department. So that's where the patients first present in the acute care setting. What does diagnostic stewardship mean to you?
Well, I, as the medical director, I spend a lot of time thinking about, the decisions that we make in the emergency department, how that impacts, stewardship, throughput, diagnostics, satisfaction, and I think it's important, as Dr. McCracken said, what stewardship means to me is making sure that we are doing our best to appropriately diagnose and treat those people who actually have urinary tract infections. And for me, the urinalysis is a very frustrating test. I think, the urinalysis and then kind of by extension the urine culture, but specifically urinalysis is one of the most inappropriately ordered,
Yes.
inappropriately collected, inappropriately interpreted,
Yes.
and inappropriately treated tests we have in medicine.
Yes.
And so I think, stewardship means to me that in the emergency department, we are doing our best to make sure the diagnosis is accurate and the treatment is accurate. And, as you mentioned, from the emergency department, we are, for many patients, the entrance into the healthcare system, or at least the hospital for an admission. So anything we do in the emergency department, appropriately or inappropriately, has a lot of downstream effects and a lot of inertia. Once if we treat if we start treating asymptomatic bacteria, or if we treat an inappropriately a urinalysis before the culture comes back. A lot of times we don't have culture results when we're seeing patients acutely, but sometimes we do if they're coming from an outpatient setting. But we have there's a lot of ramifications kind of for downstream care of what we do in the emergency department. So trying to be as accurate as we can and is important.
I think there was one study I was looking at where they said that in year 2019, there were around 36 million hospitalizations, and 27% of the patients had a urine culture done. And if even, I don't know the exact cost of a urine culture, but even if you look at it as $10, they said that would be 100 million. And more than half of them probably didn't even need that. And speaking of urinalysis, I don't think any one single parameter in the urinalysis has high sensitivity or specificity to diagnose UTI. No. I think even pyuria, I think that's the one that keeps coming up for discussion, that just presence of pyuria does not mean infection. Dr. McCracken, you did a study looking into this. Can you share some of your observations about the asymptomatic bacteria or the urine cultures and how many of them really had symptoms?
Yeah, ultimately, we didn't actually collate the data here. A lot of it was anecdotal, but we looked through a lot of charts. And, actually, even just looking at, kind of echoing a bit what Dr. Duncan was saying about downstream effects as well. I was reviewing charts as physician advisor. We review both from our system and the region. And a tremendous amount of charts we noted people were being treated when absolutely zero symptoms were documented. University of Michigan, they had a study, they indicated about 80% of those with positive urine cultures that had no localizing symptoms were being treated. And then one particular case, really, that I reviewed a chart, patient came in, AKI, altered mental status, UA, reflex to culture, started on fluids and antibiotics. Got better the next day. Provider said, grew out a multi-drug resistant organism. The antibiotic that was started would not have treated this organism. And so the provider did the right thing, said, we're going to stop antibiotics. You're better. We're going to send you home. Patient came back a week or so later. Provider that saw the patient said, maybe they missed the UTI. Maybe that was really the problem. Put him on a carbapenem antibiotic, kept him in the hospital, treated them, then sent him home. Came back a third time. Patient ultimately had been taking Lasix and was getting dehydrated, but everyone had anchored on the fact that this was asymptomatic bacteria. You mentioned the studies. I'm an Ohio State fan, but Michigan did a lot of good work with this. And they had also said they had found almost an identical case. So that one really, and they, multiple cases, not just one. So that emphasized the importance to me just in looking through those charts.
Well, thank you for sharing that. One of the biggest challenges is also convincing the patients and the family that if an elderly patient is presenting with altered mental status, by default, it is not a UTI. Even the current evidence and literature support not testing for urine just because there is altered mental status, but unless there's some other signs and symptoms of an infection. How do you do that or address that with patients and families in long-term care setting?
Yeah, I think it is. It's really developing protocols. So, for us, stewardship is the right indication for doing a urine, getting the right sample, and doing the right test, right? So that we realize that a lot of times our frontline staff actually communicate more with the family. So when, let's say, a CNA or a nurse has talked to the family and the family member says that when my mom, used to get sick when she was at home, and had this altered mental status, and we would take her to the ER and they would do a urine, and the urine was positive, so she always had a UTI. Can you please do a urine? And when that nurse kind of reinforces that belief, it becomes really hard to peel that back. So we realize that. So it's a lot of creating protocols and then educating our staff and telling them the importance of, if there is a change in mental status and it's not associated with urinary symptoms, and if you then do a urine, you're going into a rabbit hole, to your point, right? You are seeking something that is not relevant and not actually going to the real reason why they may be having that change in mental status. I think that is something that our staff now is very well versed with. The other thing that we do is when we talk to the families, we explain to them that, urine is not, 50% of the time your mom is going to be positive for urine, even with a culture and pyuria, as you said, but may not have a urinary tract infection. So let's step back and look at the full picture, because we may be missing something important. The other thing that we always say to the family is not just, we're not going to do a urine. What we say is we're going to do active monitoring of your mom while we are observing her for either getting better or actually developing urinary symptoms, and then promptly doing urine if it's indicated. So I think instead of couching it as we are not doing something for your mom, saying that we are actively monitoring. And what we have done, I'm really proud of the work that we have done in post-acute care settings, because we have an active monitoring protocol that we have put in place, and it's in Epic. So all you have to do is LTC active monitoring, and it comes up. And our staff is so well versed with that protocol that now they are immediately, in their SBAR saying, our recommendation is active monitoring. And it's just wonderful to see the staff being so well educated on that. So I think that goes a long way.
That's really great work. I think in medicine, we always feel like we have to do something when there's a change in the clinical status, and structured monitoring as a meaningful management is something I think we all have to really, do, and also spread awareness about that structured monitoring is actually doing something and actually not harming the patient by doing tests that are not needed. I think that's really great work. And how does that apply in the ED? I'm sure you have patients that are being sent to ED because they have abnormal urine culture.
And we've talked about this as we started kind of peeling off the layers of the asymptomatic bacteriuria. And I think when we first started this discussion, however long ago, I think I was pretty vocal about saying we got to make sure, as a system, we all need to be on board, whether it's, post-acute care, acute care, emergency department, or ambulatory medicine, right? Because for every weak, dizzy elderly patient who gets a dose of antibiotics and an admission in the emergency department, we see many people that come from the ambulatory setting, but with the same story. Every time they check a urine, he or she has a UTI, and we hear that so often. It's time to stop checking them.
Stop checking, right? Stop checking.
But we kind of see the same thing, and I kind of said initially that we are the kind of the entrance point and can create a lot of downstream effects. But in the ambulatory setting too, a lot of times we do get patients who are sent to the emergency department who are completely asymptomatic, have totally normal labs, but their urine culture grew out an ESBL, bacteria, and they have to come to get IV antibiotics, and they have no symptoms, right? And so in that, and it's really difficult to talk family members off the ledge when that has been created before they get to the emergency department, or if we create it in the emergency department and then pass it off to you all, or likewise the hospital to post-acute care. So it's tough. It's a very because people expect things to be done right. I mean, I think there's just an expectation sometimes that if a condition exists, there has to be a treatment or a therapy that is put in place instead of monitoring and being good stewards of these things.
I think that's the key, that don't do the test that's going to have all these downstream effects. That's not as reliable. And you mentioned initially about collection of the specimen. I think that's a huge issue.
Well, and I mean, some of the studies that have looked at the emergency department, I joke, I mean, I don't joke because it's true. I mean, when the residents know, at least the emergency medicine residents, I really kind of start going off on a tangent when they bring me urinalyses that are, to interpret and how they interpret. But, and I talked about how it's just really a horrible test. I mean, it's as opposed to just a single stick blood draw, the urine is just, there's so much potential for error there. And, you can't have a good culture without having a good sample from the get-go. And so we have a lot of caught urine in the emergency department. We don't have a lot of cleanly caught urine.
No.
And a lot of that is on us as providers and, with nursing and how processes and obtaining that. But I mean, a lot of the literature, even in emergency medicine, that has looked at contamination rates in clean catch specimens, even when there is a very aggressive campaign on proper collection techniques, in women, the contamination rates can exceed 50%. So we know they're
very
just
high.
I'm not advocating for a straight cath on everybody, but there are times when you just absolutely have to obtain.
Absolutely. I think
straight cath.
that's a big issue. That one, we're ordering a test that doesn't have to be ordered, and two, we're collecting the specimen not as clean as it's recommended, especially that midstream clean catch urine. I don't know how much we really do that. And especially elderly women. I mean, it's just, and then we start chasing after that. And think something else we have worked recently, or several years ago actually, is updating our UA to reflex protocol, that if there is presence of epithelial cells, it will not reflex, they will reject it. And presence of pyuria, bacteriuria as an indication to reflex to culture. But in catheterized patients, that's not helpful as well, because patients, there was a study, they said 100% of patients with chronic Foley's will have bacteria in the urine. And the pyuria in them is just a local inflammation from that Foley and the bacteria. So it doesn't mean infection. And then again, what has worked in your area? I know this, this is an area of interest for all of us. You shared about the protocol, active monitoring protocol, but anything else that you have done with your team? I know you've done some presentations, education, just raising that awareness, but what has worked to promote good diagnostic stewardship?
Well, I think it very much has been a team effort. And Dr. Austin has given presentations to the hospitalist, just clinical vignettes at the beginning of the hospitalist meetings to say, hey, because it keeps people's awareness. It's really difficult as we're getting patients transferred off from one provider to another to, even though it's not documented, not to treat that positive culture that came back, and just to emphasize, look and think before we do. And that thinking and that pause, I believe that, having in the medical record the fact that we have to indicate the reason for the cultures and the ordering, that's a step back. But I think that nobody likes those hard stops. Because it slows us down, but that's kind of the purpose for this. And I believe that it has made a difference. And then, so education, I do believe has made a difference, and that's education, even with, like you all were saying, given some talks, and you were a part of it with some of the home health nurses and others, because we need to be as a team. Because when a family member looks at my chart, they see 100,000 colony forming units of E. coli, et cetera. Makes it very difficult.
They see red. It needs response.
It needs work.
Is it still showing up as red? Because I'm going to follow up with our lab about that.
I would have to see.
Okay, I'll take that as a follow-up.
I don't know what the threshold is for them, but even
Because colony count does not mean, high colony count does not mean infection. Just like pyuria does not mean infection.
Right.
Yeah.
Right.
So I'll follow up. And you mentioned about active monitoring.
Yeah,
Anything else?
we have actually, again, we have a very robust, protocols for different triggers. So, I mentioned the right indication. And so we have low minimum criteria that we follow to even send a urine analysis. So low minimum criteria for, treatment is something that is established criteria in post-acute care patients. And so we follow that low minimum criteria when residents, internal medicine and family medicine residents come in. That's the first thing that I go over. We do very robust education about, it doesn't matter if the urine is looking funky or it's smelling funky. I've not met a urine that actually smells good. So I'm like always saying that this is not an indication. And I think, our staff is very well versed with that. I talked about active monitoring, and our active monitoring protocol actually has vital signs monitoring, increase in PO fluid, because a lot of times these urinary symptoms can happen, as you mentioned in your case, due to dehydration or hypovolemia, and now the urine is concentrated and the patient is feeling it. So we have that, a prescribed amount of fluids that the patient needs, and also we have incorporated in our nursing home in the active monitoring criteria the 100-100-100 sepsis screening tool. So it's really good because, if the patient is, something is happening with the patient, we are able to catch that before the patient gets septic. And so we are able to catch those early, either a urinary tract infection or other infections through that criteria. Further, what we do have is actually McGear criteria, which is a surveillance criteria that our infection preventionist and our pharmacist actually look back. It's a look back criteria to see if this urine that was ordered or treated had symptoms associated with it. And did we have the McGear criteria fulfilled? We are doing monthly meetings for that. Our infection prevention control and antibiotic stewardship meetings are monthly. And we are looking back at that McGear criteria and seeing how many deviations from that we have had, and is there a good reason why? And then we take that as an opportunity to educate, or intervene. But we also are doing not just good stewardship of cultures or urine, but also antibiotic stewardship. So we have a prescribed, based upon our antibiograms, a list of medications that you could have and the number of days. So we are kind of trying to set systems where, it kind of helps them succeed in good practice.
I think this is really great. Thank you for sharing that. Dr. Duncan, you have really helped us in updating some of the process in the ED. Can you share?
Yeah, well, so in the emergency department, we are, kind of held to a lot of standards on timeliness of care. And so, as you all know, we utilize protocols, triage protocols for a lot of patients who present to the emergency department, which are symptom-based, ordered by nurses or APPs or anyone, physicians, residents who might screen patients. We suffer in our emergency department, just like most EDs do nationwide, with throughput issues due to admission holds, volume, and so we use these triage protocols to try to help expedite care. But, one of the downsides to that is that you're always at the risk of over-ordering tests, right? And so, a lot of our protocols did include urinalysis, protocols for, altered mental status, abdominal pain, sepsis, generalized weakness. I mean, there's multiple ones that we have. We have many protocols, but a lot of them did include a urinalysis with a reflex culture, right? And so, right now, every time I query lab, it's pretty much consistent. About 1/3 of all of our patients that present to the emergency department get a urinalysis. That's just 1/3. It doesn't matter what their complaint is. 1/3 can get urinalysis, and it's hard to believe that in Gainesville, where we see almost 300 patients a day, that 100 of them need a urinalysis.
Wow.
Right? So we with protocols we try to favor efficiency, but there's always a chance that we're going to overorder. But I think where we feel it the most is with the urinalysis. So we've worked to remove urinalysis with reflex culture from a lot of the triage protocols where they're just not needed. But when we do feel like they are needed for certain complaints, some of the work that we've done and we've talked about, which we're in the process of doing, is just removing the urinalysis order from all of our protocols, but then substituting that with an order to collect and obtain urine and hold it. So that way we can send the urine after the provider's seen the patient, evaluated them, and determined if a urinalysis and then a culture is clinically indicated. So I think that will help a lot.
Yeah.
But yeah, we've really seen. I think the urinalysis with reflex culture order in the emergency department has really probably unnecessarily ordered a lot of urinalysis. But as opposed to maybe the patient who got a CBC based from a protocol who didn't need a CBC, that doesn't have a tendency to tear through the system like a urine that was inappropriately ordered and collected and interpreted and treated and then cultured out. And so we those changes have been sent to Epic and are in the process of getting rolled out. So I think it's going to be really interesting
That's
to
exciting.
see when that change is
really
made.
good. Yes.
One, what happens to the number of cultures that are ordered from the emergency department, or urines and cultures. But also, how are we missing? We're over ordering them. We're probably going to catch a few.
Yes.
But are we missing any? Has this caused any harm?
Yes,
Which I think you could probably argue that we're causing more harm by over ordering than we are by missing two. But I think though what's really important also for the emergency department and anywhere is I think we really need to develop a good campaign where we really focus on appropriate collection techniques, right? Because we can't count everybody.
Yes,
I mean, that's
so
just
important.
not, and a negative urinalysis is great, right?
Yes.
Because that rules out a lot of stuff.
Yes.
The problem is that when it's inappropriately collected, and so, I mean, whether it just, provider education, nursing education, patient education on how to collect these things, reinforcing that we don't use samples from a PureWick or a bedpan, But one of the challenges that we face too when I talk about appropriateness is with our protocols is someone who comes in with frequency dysuria, suprapubic pain, and again gets an abdominal pain protocol, gets the same urinalysis ordered that somebody comes in who's burping and belching and has epigastric pain. That patient doesn't need a urinalysis. So that's where our protocols fail us, right? Because it just kind of paints a broad brush of when these
There
tests
was a case I reviewed years ago of somebody with abdominal pain and diarrhea. Actually, it was C. diff. And patient got urine tested, grew ESBL organism, and somehow presence of a MDRO, multidrug resistant organism, seems to prompt treatment. But even if it was not MDRO, so patient with C. diff getting other antibiotics as well, which can really cause a bad outcome for the patient. There was, to your point, you mentioned early on about patients presenting with altered mental status or just this unclear presentation. There was a study I was reviewing recently where they said the patient actually had stroke, CVA, but then was diagnosed as a UTI. Recently, again, this keeps happening, right? That urine distracts us from what's actually going on with the patient. I hope after the implementation of the changes that are going through the EPIC, I hope we'll see how the data, what data shows and publish and share.
We should probably sit down and kind of look at what our, collection rates are, what our, positive urinalysis or positive culture rates are, and look at kind of how the volume and
Exactly.
And kind of monitor that and kind of see.
Absolutely. Especially patients with Foley's, It's just what we see is that we get urine from that Foley that's been in there for a month instead of changing it. Our protocols say if it's been in for 3 days or longer, change it unless there is a contraindication. And if you really need to collect based on the proper indication, collect it from that new catheter. Don't collect it from the back. But again, we do see that as well, and then we keep treating. And then we see our C. diff rates go high, or RMD or O rates go high. Again, I think the three of you in your settings have been such proponents and advocates for good urine culture diagnostic stewardship that I'm really hoping with partnership with all of you, our nurses, that we make some positive strides in the direction of making sure that, we decrease unnecessary urine cultures. And then the specimen as well, I know you have had that in the long-term care. We are looking into the transport, especially if the lab is not on site, or if the cup sits in the patient's room, even if on-site lab, because having the preservatives so that the bacteria do not proliferate is so key, that we make sure we have collecting properly and processing, or processing, transporting it properly, and then reporting. There was a study specific to ED. Years ago, I reviewed that, where they said they didn't report urine culture results. They just asked the providers to call. And they got so few calls. The results.
No one wants to make those extra phone calls.
That's it. Yeah. And if there are urinary symptoms, maybe they will call. So, but you bring up a good point. I think it's so important to, first of all, post-acute care, we do have people who have long-term catheters. And I think it's so important to, really draw that line, like 48 hours, if the catheter has been in place, then you have to change it and you have to get a fresh specimen. The other thing that I see is sometimes with these people with, long-term catheterization, there's sedimentation in the catheter and partial blockage. And the symptoms actually may be coming from the catheter being blocked and the urine being a lot in the bladder rather than an actual UTI. So when we have those kind of symptoms, we ask them to change the catheter. And then the nurses will report, there was 1,000 cc return. Do you want me to send this urine to the lab? And I'm like, that's been sitting in the bladder for some time. Maybe not. Maybe let's see how this progresses and put them on active monitoring. And then see if the urinary symptoms still are there. Let's then send a urine. Let that happen. So I think that is important. The other thing that we are seeing, actually talking about diagnostic stewardship, is those urine PCR testing, and I know, that has started to wreak a havoc in post-acute care settings because patients are going out to specialists and they are getting these PCR tests. Now think about, the PCR that we're doing for COVID. It picks up everything. Absolutely. And think about what it is doing to a urine. It's picking up everything, and I cannot tell, which organism is involved. So we will get these results back and a request for treatment from some of the specialists, but there are 3 or 4 bacteria, and many of them are resistant, and you don't know if they are just fragments or how much they are actually contributing to a urinary tract infection. So we are basically not using PCR testing at all.
It shouldn't be.
Yeah.
It's too early. We don't know where it fits. We don't know what's the benefit to the patient. We recently saw a report with 7 organisms.
Yeah.
I've seen ED referrals, ID referrals for some of these molecular tests.
Yeah.
I've seen a statement from post-acute care, but I've not seen anything from other societies yet. Maybe there's one out there not recommending use of molecular tests, especially for contaminated urine specimens, a site that is not sterile. So I think it's too early to know where they fit. We should not be really using them. Something else that I wanted to bring up is, especially in patients in the hospital who have an acute change in mental state, or not just mental state, any clinical presentation change, the concept of pan cultures. Before, fever seems to be the most common cause. If patient has fever, pan culture. Any change in clinical status, pan cultures. How do we move away from that? Urine should be really unless they have clear signs and symptoms of a UTI, it should be more of a later thing than just the first thing. Patient has been vomiting, concern for aspiration, and then we get a pan culture.
No, I think you even sent the Time article that, from the popular press, that it is becoming more of something I think it's starting to be realized. When I was in med school, this really wasn't talked about as much. And I think the best way is we need to make sure that people understand that there is harm associated with this because of just the cognitive bias, the anchoring, all the things we get. That this test is not specific. It is very much dependent upon the clinical symptoms the patient has, and that ordering the test itself and getting the information, if the information doesn't correlate with an actual a plausible diagnosis, then it can actually cause harm. And so I think we need to, stop and be deliberate about it. And when I was in training, pan culture was very common. I don't believe that's being promoted in the same way, but it's still being done. And that's a holdover that we're seeing. So I think we need education.
Yeah, absolutely. I think this has been such a robust discussion, a lot of great takeaways. Any final points from each of you?
I'm actually very excited about the progress that, in ED, because, it's so important for me as a post-acute care physician and medical director for post-acute care, it would be wonderful for patients to, if they are sent to ED, not have urinalysis as a part of the panel, which used to be a standard in a lot of emergency departments, and our emergency department basically coming out and saying, no, we're not going to do that. And I think that will go a long way, because if for women, it's a coin toss, right? If they actually have a UTI, or is this asymptomatic bacteriuria? So it's really, really encouraging. I'm so excited to see that, and I think the collaboration that we have, in bringing about these good practices is exciting to me, and it's all about the team,
Yes.
Absolutely.
Yeah, I think, I'm excited about that as well. I think it'll be an impactful change for the system. I think for anybody listening to this podcast, especially if any of our learners and residents are listening, I think the take-home up point I would make is, anytime you see a urinalysis, or consider ordering it based on, are there real clinical indications for getting it, but also, when you do have one that just falls into your lap, make sure you're being very deliberate about how it was collected. Even asking the patient, how did you collect this urine? You'd be surprised how many, I just sat down and peed in a cup. They didn't do any, but, how is it collected? What symptoms are they having? And really consider, does this patient have a urinary tract infection? And it's a very simple test, but you really have to be very deliberate in how you interpret it and consider treating it. So. Hopefully we can kind of help make that easier on everybody from the emergency department. But like I said, it's the most inappropriately ordered, inappropriately collected, inappropriately interpreted, and inappropriately treated test that I know of in medicine. And
Absolutely.
I think we can change that, but the downstream effects of it are pretty catastrophic.
Yeah,
really.
I believe we can change that. It's going to take
Yeah.
a lot of time, but yes, I think we can change that if we work together. And again, it's so important. Urine culture diagnostic stewardship ties directly to what we do in infection control and antimicrobial stewardship. And bacteriuria doesn't mean infection. Pyuria doesn't mean infection. MDRO doesn't mean infection. Only time you would treat asymptomatic bacteria is if they're pregnant or prior to a urological procedure. So I'm really looking forward to how all these changes we're implementing in different settings will impact our urine culture diagnostic stewardship. Anything from you, Dr. McCracken?
No, I think just what everybody has said, and the fact that we really need to be deliberate and thoughtful clinicians. It's not about just ordering a test, and they wouldn't need us if that were the case. If we could simply get a test and make the diagnosis, then why do you need a physician or an
That is so
APP
true.
or someone else to do it? So that's what this is all about. It's not just getting the test, but thinking about it, listening to your patient, examining your patient, and making your decisions based on all of that.
Very well said. Thank you so much for joining today.
Thank you.
Thank you.